Hello everybody, today, November the 14th, it's Nutrition Day. You are very welcome to participate in our project, in your project that started already in 2006. We have received already photographs of the first groups that are active in Nutrition Day. You see that we have already collected over the years 2006 to 2023 data from more than 74 countries, more than 15,000 units, and more than 300,000 patients and residents. Nutrition is so essential for patients that our aims are remaining since many years. Raise awareness for disease-related malnutrition, improve quality of care provided to patients, and we are empowering you to follow this path to improve quality by providing a tool to benchmark and monitor the risk profile of your patients and the nutrition care that you are providing. Moreover, this large database serves benchmarking and research in observational research on nutrition care. The success of Nutrition Day lays also in his original design. It's a one-day data collection followed by outcome recording 1 month later for hospitalized patients. In ICUs, outcome may be recorded after 2 months, in nursing homes and primary care after half a year. The basic idea is to ask patients about their nutrition history, the risk factor that they are bringing into the hospital, how was their course in the hospital until Nutrition Day, and the caregivers, we ask the medical information about clinical nutrition provided, the diagnostic categories, and after 1 month's outcome. It's very important that you recruit the majority of patients of your unit to have representative data that can serve your benchmarking efforts. The tool of Nutrition Day shares a common language for all of you. It has been translated in more than 35 languages. This is the case for the questionnaires, and it will be also for your reports, so that there is no language barrier to participate. Moreover, the data are anonymous. We do not collect anything that allows us to trace back to your patients or your hospital. It is free of costs for you, and it is easy to be applied. It is provided to you by Espen and Medical University Vienna. The final result of this tool is that you receive a report that summarizes your data on the one hand in a quality report, and on the other hand in a numeric report that brings back to you the summary of all your entered data. The data that you will receive with your report are compared first at the level of the unit with units from the same specialty as yours. Moreover, on request, you can get a center report so that you have a reference for your whole hospital where the individual unit can be compared to. The national reports that are published after final data cleaning report the data for countries with a large participation, data that allow to compare countries, and finally, overall data are then the reference. The questionnaires from Nutrition Day are organized for different settings. On the one hand, the hospital with the special data for cancer patients and for surgical patients. On the other hand, data from intensive care units, then the data from nursing homes and long-term care residences, and finally, the newest project data from primary care and ambulatory services. Today, I will report you a few data from the area of hospital patients. You all know the major nutrition-related risk factors in hospitalized patients. But did you really know that only 8% of patients are obviously malnourished because they have a BMI below 18.5? This is only observed in about 8% of the patients. On the other hand, you can have a low BMI only if you have lost weight, and lost weight is observed in 41% of the patients. On the other hand, you would not lose weight without eating less or inflammation. And 32% of the patients report that even before being hospitalized, they ate less than normal. And finally, when we are looking now at what you can observe today at Nutrition Day, 49% of the patients did not eat their full meal. These observational data about risk factors become relevant when we look at outcome. In this cartoon, you see first the prevalence of the different BMI categories. So again, in violet, you see the 8% of patients with low BMI. You see that roughly 45% have a normal BMI, that nearly 30% have an elevated body weight with a BMI between 25 and 30, that approximately 12% have a BMI between 30 and 35, 4% between 35 and 40, and in red, 2% have a BMI above 40. But now let's look how this is mapping to outcome. And you see that in the category with normal BMI in green, the mortality within 30 days is 2.85%. This mortality increases with an odds ratio of 1.5 for those with low BMI and appears to be lower in those with overweight and little obesity, and then increases again in the very obese. You see also that men have a poorer outcome than women in blue, and that age is an important factor for outcome in hospitalized patients. These data are adjusted for each other. In this overview of the BMI profile, again, from at the bottom, very low BMI to very high BMI at the top, over the years since Nutrition Day collected data from 2006 to 2023, it is very stable. This indicates that being ill may be associated with certain BMI categories. And despite increasing obesity in the population, we find a stable profile in hospitalized patients. You see on this cartoon quite clearly that the proportion of patients that have lost weight in orange is quite stable since 2006, because it is related to being ill. Since the year 2016, you see that we have included also in green-orange the part of patients that have an intentional weight loss. Something below 10% of the patients lose weight unintentionally. In yellow, at the bottom of the graph, you see that the proportion of patients that have increased weight. The important factor is that compared to patients that have a stable weight, patients that report weight loss have a 3 times higher mortality within the next 30 days. Of note, the gray part of roughly 10% of patients that tell us that they do not know whether they have lost weight have a similar risk than patients that have lost weight. We can only speculate that it may be patients that do not feel enough of their body. And now let's look together at factors that may be modifiable because they can be observed during hospitalization, like how much did you eat today? And you see on the prevalence data that less than half of the patients have eaten their full meal. These are the green dots. The pale gray indicates the quarter of patients that have eaten less than half of their meal. The black, 12%, have eaten a quarter, and the orange and the red ones have eaten nothing. The red ones would have been allowed to eat. And now let's relate this factor again to outcome. And you see a clear stepwise increase from the reference mortality of 1.75%. Patients that eat only half of their meal have a twice higher mortality within 30 days. Patients that eat a quarter have increased their chance to die by a factor of 4. And patients that do not eat in red, despite being allowed to eat, have an increased mortality of more than 5 times. Patients where the medical decision is not to allow to eat have also, in orange, a slightly elevated chance of dying by a factor of 3. But it is much lower than in patients that are allowed to eat and do not eat. In this profile of the eating on Nutrition Day over the years since the start of Nutrition Day in 2006, we see some positive trends. In green, the proportion of patients eating all are slightly increasing over the years. And importantly, in orange, the proportion of patients that are not allowed to eat is slightly decreasing. So both of these factors indicate that there is a trend to positive change. Let's together separate these nutrition-related risk factors into 3 groups. One group are the nutrition risk factors that the patients are bringing from home into the hospital. They are in pale orange background color. It is BMI, it is weight loss, and poor eating before admission. Then 2 factors that cannot be changed at all. It is sex and age with a gray background. And then on the right-hand side, you see 2 modifiable factors because they can be observed and they are active while in hospital. On the one hand, it is eating on Nutrition Day, and on the other hand, it is how mobile are you in hospital. When we summarize this data, and when all the factors that are above 1 increase the risk of dying, and those that are below the line of 1, they are favoring a better outcome. And we clearly see that the highest effect on mortality is related to the modifiable factor with the green background. So it is changing patients from being bedridden to mobile or increasing their intake. We have already, in an analysis that we have done for our German colleagues, found out that length of stay even can be shortened with an intervention that is increasing intake in hospitals. There are basic tasks that can improve intake. It is first of all intake monitoring. This is probably more important than consulting experts because first you need to know and identify patients that eat less. What we have found a few years ago is that less than 50% of the patients, regardless of the presence of their risk factors, have their intake monitored. But after monitoring of intake, what would you do? And I think in addition to intake monitoring, either you do counseling, you make a nutrition care plan, or you use oral nutritional supplements, enteral nutrition and parenteral nutrition in patients that do not eat enough. How is this done in relation to the individual eating amounts? On the left, you see the proportion of patients that indicate to eat a quarter and then receive in blue ONS, receive in dark green parenteral nutrition, or in pale green enteral nutrition. We see a clear trend of progressively using over the years more oral nutritional supplements in these patients eating a quarter. The same can be seen in patients eating nothing despite being allowed to eat. Surprisingly, the proportion of patients with parenteral and enteral nutrition in green is decreasing over the years. Overall, it should be noted that only about 1/3 of the patients eating a quarter and approximately 40% of the patients eating nothing receive either ONS, enteral nutrition, or parenteral nutrition. In those where there is a decision because they are not allowed to eat, the proportion of patients receiving nutrition support in form of ONS or enteral or parenteral nutrition appears even to decrease over time. We cannot explain this now, but it could be that shorter hospital stays or application of the ERAS principle may be a driver to decrease overall stay in hospital where there is an opportunity to intervene. Our team has developed several years ago two forms of reports. On the one hand side, a numerical report that brings back all your data. On the other hand, a graphical report that summarizes risk factors and quality indicators. So we look at process measures. We can start with the most simple process measure, that is, are you weighing your patients at admission? And you see that this unit, that is real data, is weighing few patients, comparison with overall nutritionDay data or even the same country or the region. Finally, I would like to address to you one important point. If you embark in the process of benchmarking your nutrition care processes, please try to follow one important advice. If you want that your data are representative for your unit, please try to recruit a maximum of patients and do not only select certain patients for participation in nutritionDay. If you select patients, you have no full overview of your practice. This is illustrated in this cartoon that clearly shows that if you are recruiting the majority of the patients, excluding only the few that clearly refuse to participate, it's often about 5%, so 1 out of 20, you will get much more out of nutritionDay with your participation. With this final important remark, that applies of course also for outcome that should be recorded for all patients, and that allows you to receive the certificate for good participation if you recruit a good number of patients and if your outcome reporting is nearly complete. With this final suggestion, I wish you very good luck today on nutritionDay with collecting data, with entering data in the database, and then looking at outcome after 1 month. You will have a first look into the report to see whether your data appear to be complete. Then you have still a chance to correct some data or to enter what is missing. And thereafter, you can start your local benchmarking process, your local explanation to your team what the situation is that you have to face. Congratulations to all of you for your decision to participate in Nutrition Day. If you encounter any problem, or if you have some questions that you want to be answered in the future, please contact our office